Dear President, dear colleagues, I want to thank the organizers for having me, and in the next minutes we are going to discuss an interesting case regarding bicuspid aortic valve anatomy and TAVR. And why this subject is of great interest is the fact that we face this issue in almost 20% of the TAVI cases in Western population, and we face this anatomical variation even more often in Asian population. It is also an issue that we face it usually in younger ages. It is characterized by great anatomical heterogeneity having to do with a number of commissures, heterogeneity having to do with a number of sinuses, the calcium burden, the localization and distribution of it, the length of the and the height of the coronaries. We have high frequency of coronary anomalies, the coexistence of aortopathies that occur up to 60 to 80% of the cases. And also it's of high interest because we do not have solid data based on randomized controlled trials. It is also reflected in latest published guidelines. The European guidelines do not recommend TAVR as an option. From the other side of the ocean, the American guidelines recommend them as an alternative for surgical approach when the patients are of high prohibitive surgical risk and when there is no aortopathy. Here comes our case. This is a lady, 82 years old lady, who came to us due to congestive heart failure symptomatology. She has no coronary artery disease. The ECG at the baseline had a PR interval of 230 milliseconds. And by the baseline echocardiography, you can appreciate a severity at the level of aortic valve stenosis with a mean gradient of 43, an AVA index of 0.54, a borderline left ventricular ejection fraction, and mild left ventricular hypertrophy. And also you can appreciate at the baseline echo the fused valve configuration at the aortic valve with left to right cusp fusion that you can appreciate in the parasternal short axis at base. So we proceed further with coronaries. The coronaries revealed no relevant issues, right dominancy. The hemodynamic assessment of the aortic valve stenosis confirmed the severity. The height, as it was estimated by the CT analysis, was sufficient in order to avoid any coronary obstruction. And the CT analysis at the level of the aortic valve revealed a moderate to severe calcification, type 1 with left to right fusion according to severe classification, functionally 3i commissural raphe type with no relevant asymmetry based on the Bavard classification. The anatomy at the level of the aortic root revealed no any relevant calcification at the level of the LVOT, no severe ellipticity at the level of the annulus, and you can appreciate by measuring the dimensions 4 millimeters above based on the Bavard registry and based on the configuration at the aortic root and the landing zone. You see that we have a tubular configuration at the landing zone based on the data derived from the Bavard registry and presented by Dieter Tsetze. So based on that, sizing of the new implanted valve must be done based on the annulus diameter. There is no any relevant issues regarding ascending aorta and aortopathy, and the annular angulation was in the normal range. And the iliofemoral system, the peripherals were with no relevant issues, no severe tortuosity, no calcification, no relevant stenosis. So based on all that, we have an old lady who had an anatomy which is favorable for transcutaneous aortic valve replacement, and who were possible to proceed with that through the transfemoral approach. The data that we have up to now revealed that based on the low-risk bicuspid study for the Evolut platform and based on the pattern 3 bicuspid registry for the Edwards platform, when we compare the transcutaneous treatment for tricuspid versus bicuspid anatomy, there was no relevant difference in terms of MACE. So that was the reason why 2022 the BAV and the TAVR approved by FDA. Based on real-world data coming from observational studies, when we compare surgery versus TAVR in such anatomies, long-term there is no huge difference in terms of mortality. So In each case, we have to individualize the treatment approach. And according to the device that we have to choose, we have data revealing that both most commonly used devices, the self-expandable platform and the balloon expandable platforms, may do not differ in terms of mortality. It seems, however, that the self-expandable platform may have a more favorable anatomical features. That's why we decided to proceed with a new generation device, the Hydra valve. This is a valve which has certain anatomical features that are very important during the procedures, such as the no flare at the inflow portion, diminishing the risk of conduction abnormalities, and also the large frame cells at the level of the coronaries, making the engaging to the coronaries easier after the procedure. Here is the valvuloplasty, semi-compliant balloon under rapid pacing, and thereafter we proceed with a gradual release of the valve. We proceed with implantation at cusp overlap view. You have to try to be as high as possible, and this is the final result, a stable platform, no relevant paravalvular regurgitation, and great hemodynamic performance, having a mean gradient less than 10. The technical characteristics, we have a procedural time which was less than an hour, the fluoroscopic time was less than 20 minutes, and the device time was less than 5 minutes. A couple of hours later, the lady developed high AV block requiring permanent pacemaker. Otherwise, the rest of hospital course was uneventful, and she was discharged on day 3 after the implantation. And 1 year follow-up, you see a stable platform, a good left ventricular ejection fraction, and a very good hemodynamic performance with a mean gradient of 8 millimeters of mercury. And with that, I want to thank you for your attention.
Very elegantly done, Adonis. Any questions from the panel? My surprise here in this case is that you have a bicuspid valve than an 82-year-old lady. You would have expected a much younger patient with a bicuspid valve to develop symptoms, and she was neglected. What happened? Why did she come so late? Or it was a very low progress of the disease? What is your take on that?
She doesn't have any other cardiovascular risk factors that may accelerate the propagation of the calcification of the valve. And she was a type of valve which was showing by the, you can appreciate that the ascent aorta was in normal rate, so you didn't have any significant hemodynamics that may influence the fast propagation of the severity of the aortic valve stenosis.
Perfect.
Congratulations, Andoni.
It was a yes.
I think we are talking about two different subsets. We have the congenital bicuspid valves that come with those orthopathies or coarctation of aorta, etc., 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 and maybe predominantly regurgitation or stenosis. I think this is not inherited. It's degenerative. Sometimes those raphe of the valve stick together, and it's not congenitally bicuspid valve. It's a different story because there you have to consider other things. You have a valve in a very young person, so you have issues of durability of the valve beyond procedural aspects of asymmetry of the annulus, etc.
So you're saying that it was a functional,
may I make
not a congenital?
Achilles, may I make a comment on that? There is a great classification based on Bavard registry. And as you can show in my slides, I mentioned that it was a tricommissural bicuspid type. So this is part of the BAV morphology that we face. So BAV, it's an anatomical variation with great heterogeneity. And that is also the reason why we do not have a standard algorithm approach in such cases.
Great. Just one last comment. I think it's very important to distinguish between what we said, the functional bicuspid or the congenital bicuspid is a very good evaluation of the CT. When you have calcification extending up the wall all the way up to the STJ, then it's probably a congenital rather than a functional bicuspid. Anyway, Adonis, thank you very much. Wonderful.